But before we begin, please take a moment to like this video and subscribe, as it will really help out the channel. So for the thyroid examination, like any other examination, we're going to follow our normal protocol of meeting the patient and doing our wiper. Good morning, sir. I want to examine your neck today, please. May I go ahead?
Please do.
Thank you. So the position of a thyroid examination is the patient sitting, and the exposure is the patient's neck and the superior chest. Okay. So examination of the thyroid also includes inspection, palpation, percussion, and auscultation, and some special tests, which we'll see. So to begin our thyroid examination, we're going to start with neck inspection. So we're going to look at the patient's neck on both sides, looking for any swellings, scars, and we ask the patient to bring out their tongue. Can you please open your mouth and bring out your tongue? Thank you. Can you swallow? So by asking this, we're trying to differentiate between a thyroglosal cyst and a thyroid mass. The thyroid gland originates from the foramen cecum, which is at the back of the tongue. It travels down through a duct down to the neck. As we grow up, that duct disappears, but in the case where that duct remains and forms a cyst, that is called a thyroglosal cyst, and it classically moves with tongue protrusion. A true thyroid mass, however, does not move with tongue protrusion but moves with swallowing. This is because the thyroid gland is attached to the trachea through the Berry's ligament, and the trachea is attached to the larynx, which moves up during swallowing to assist the epiglottis in closing it off. So as we ask the patient to bring out their tongue and to swallow, we're trying to differentiate if this is a true thyroid mass. After that, our inspection is done. Next is we move on to palpation. For palpation, we start by palpating for the 4 T's. So temperature, tenderness, tethering, and tracheal centrality. So to check for the temperature, we will need the patient to pull up their sleeves. Can you pull this one? And we start from what we expect to be normal, and then abnormal, and then normal. So it should be normal, abnormal, normal. A warm thyroid gland might indicate a thyroiditis. So after the temperature comes tenderness. But before we do that, we ask the patient, sir, do you have any pain in your neck?
No.
If they don't, we use one finger to just feel at the patient's neck while looking at their face to see if they wince. So a painful thyroid swelling might also indicate a thyroiditis. Next is to check for skin tethering. To do that, we simply just pinch the skin of the neck to see if it's attached to the mass, which, if it is, might indicate a sign of malignancy. Lastly is we check for tracheal centrality, and we do that using the 3 of our fingers like usual. So 2 fingers on the sternal notch and 1 finger running down the trachea to make sure it's central. After that, we move on towards the back of the patient. So in the back of the patient, we need to position the patient's head by putting our thumbs on the occiput of the patient and slightly pressing the patient's head down to flex the neck. And the rest of our fingers will be on the patient's neck. To confirm that we're on the thyroid gland, we ask the patient again to please bring out their tongues. Open your mouth and bring out your tongue. Thank you. And can you swallow? So after we confirm that we're on the thyroid gland, we now start palpation. And to palpate for the right side, we have to tilt the patient's head towards the right to relax the neck muscles. So sir, can you please tilt towards your right? Thank you. And then using the opposite hand, we stabilize the neck, and then we rub using the ipsilateral hand. We do the same to the other side. We tilt towards the side that we want to palpate, push the other hand to stabilize, and rub with the ipsilateral hand. Thank you. After that comes palpation of the carotid pulse. So to palpate the carotid pulse, remember that there are certain rules that you have to follow. And one of the rules is that you cannot palpate both of them at the same time. So to show the examiner that you're not palpating at the same time, one hand should be at the head of the patient and the other one on the medial aspect of the sternal thyromastoid to feel for the carotid pulse. You switch. An obliterated carotid pulse or a non-palpable carotid pulse is called a Berry's sign, meaning that the thyroid malignancy has most likely invaded the carotid sheath. After the carotid pulse comes palpation of the lymph nodes. So we feel for our submental, submandibular, preauricular, postauricular, occipital, anterior cervical, upper, mid, and lower, posterior cervical, and supraclavicular. Sir, can you please raise your shoulders? Thank you. Lastly, for palpation, we palpate the scalp for any evidence of swellings. So if the patient is wearing a hat or a wig, it's advisable that you ask them to take it off. So after that, we start our eye signs and we begin from behind. The first eye sign that we test for is called the Ziegler sign. This is just a fancy name for proptosis. So to do that, we extend the patient's head until we can see the eyebrows, and we slightly bend to see if we can see the eyeballs extending beyond the eyebrows. If that is positive, we say the patient has proptosis or that the Ziegler sign is there. So how do you remember this? So Ziegler, right? There's zigzag inside, which sounds like zigzag. And when the patient extends, you can draw zigzag lines on the patient's face. So there's a zigzag, zigzag, zigzag. So that can help you remember the Ziegler sign, hopefully. The next sign that we look for is called the Thyroid sign. This is when we just look at the eyes of the patient and we tell them to look straight ahead. And we're trying to see if there's infrequent or lack of blinking. So when patients have proptosis, because the eyeballs are protruding out, it can be hard for them to blink like normal. So if the patient looks like they're not really blinking well, or that there's a staring gaze there, then we can say that the patient has Thyroid sign. So how do you remember this now? So Thyroid sounds like stare. So the patient is staring into space, he has Thyroid sign. So the next sign that we test for is Thyroid sign. So we look at the patient to see if we can see the upper sclera. So normally when we look into a patient's eyes, we can see the pupil and slightly part of the lower sclera, but we can't really see the upper sclera. So when we can see the patient's upper sclera, we can see that there's lid retraction. Okay, so if you think about it, Thyroid represents lid retraction. The fourth sign is called Joffrey sign. And how we test for Joffrey sign is we ask the patient to look straight ahead and then to focus on our finger, and then keeping their head still with your hand, you ask them to follow the movement of your finger with their eyes. Can you please follow the movement of my finger? And you raise it up until you can see forehead wrinkling. If there's no forehead wrinkling or the forehead looks smooth, you can say that there's Joffrey sign. So how do you remember this now? So Joffrey, because the forehead is free of wrinkles. That's how you remember it. Now on to sign number 5, which is called von Graf sign. So how you do this is, after testing for your Joffrey sign, and you come back slowly to the midline and you tell the patient to follow the movement of your finger with their eyes. So you quickly drop your finger to see if the upper eyelids also follow. If the upper eyelids will not follow, then you can say that there's lid lag. So remember, von Graf is the only eponym we mentioned that has 2 words, and lid lag is also the only sign we mentioned that has 2 words. So von Graf sign for lid lag. Next is to check for ophthalmoplegia. So patients with exophthalmos might have some extraocular edema, weakness, and that might lead them to have ophthalmoplegia. So how we do that is we ask the patient to focus on our finger and follow the movement while keeping their head still. So please follow the movement of my finger. And you make a H sign, testing all extraocular muscles. And then you ask the patient to tell you, sir, do you have any pain or double vision as I'm doing this?
No.
Okay. So if the patient can follow all the movement, then we can say there's no ophthalmoplegia. That's the 6th eye sign. The last eye sign is called Mobius sign. So how you test for Mobius sign is you ask the patient to look straight ahead, and then you put your finger in front of them and you ask them to look at your finger. So the patient should be seen looking at your finger and the eyeballs should be seen converging. Okay, so that's Mobius sign. So how do you remember this now? Well, of all the eponyms we mentioned, Mobius sign is the only eponym with the shortest amount of letters. So if we spell it out, M-O-B-I-U-S, that's 6 letters, is the shortest, meaning you have to look very closely at the sign to see it well, and your eyes will converge as you do that. Does that make sense? No, but will it help you remember? Yes, you're welcome. So after finishing with your eye signs, you're completely done with palpation, and the next is percussion. So what we do is we percuss for a external extension. And how we do that is we tell the patient to slightly pull down on their top. So we locate the sternal angle, or the angle of Louis, and we start percussing there. It should remain resonant. If at any point it turns dull, then you can start worrying about retrosternal extension. Lastly, on the neck, we move on to our auscultation. Using the diaphragm of our stethoscope, we just listen over the thyroid, checking for any thyroid fluids. So the next is to move on to the hands. Can I please have your hands, sir? And you look at the palms and feel for any warmth and sweating. Then we turn around and look at the dorsum of the hand and inspect for any clubbing. Then we check for fine tremors, and how we do that is we ask the patient to please hold out your hands, spread your fingers. Then we put 2 separate pieces of paper on top of the patient's hands and we observe for any fine tremors. After that, we check for the pulse of the patient, and when we check this time for the pulse, we're checking for 2 things: rate and rhythm. Patients with thyroid disease can have abnormally high or abnormally low rates, and for the rhythm, because they're also prone to arrhythmias, especially atrial fibrillation with hyperthyroid patients. After the pulse, we move on to check the blood pressure and the biceps reflex. Patients with hyperthyroidism may have hypertension as well as hyperreflexia. After finishing with the hands, the last is to move to the legs. So in the legs, what we're looking for is any scaly appearance for pretibial myxedema, and we also press while looking at the patient over the shins. Release our hands and rubs. Pretibial myxedema is typically non-pitting. The last thing to do is to ask the patient to put their hands on their shoulders, can you please, and then stand up. Thank you. You can sit down. Doing that will help you assess for any presence of proximal myopathy. This brings us to the end of our thyroid examination. Remember the eye signs: Ziggers for zigzag on the patient's side profile, Stelbach for staring gaze, Dalrympe for retraction of the eyelids, Joffrey for forehead being free of wrinkles, Von Graff for lid lag, and then Mobius because it's the shortest and you have to look closely to that, your eyes will converge, and then ophthalmoplegia. So if you have any questions, leave it in the comment section below.